I'm the System Science Manager at the Prevention Center, and I'll be your host today for this webinar that we're bringing to you. And before we begin, though, I would like to acknowledge the traditional custodians of the lands on which we are all meeting today. I'm joining you from the lands of the Kombumerri people here on the Gold Coast, and I extend my respects to their elders, past, present, and emerging, as well as the elders of the lands from which you are all also joining today. So thank you for being here. For those of you who are new to the Prevention Center or are joining today as guests, we are a national collaboration with the aim to strengthen the chronic disease prevention system in Australia. And we host the Emerging Leaders Network as part of achieving that aim. And this is a network of over 400 early to mid-career researchers, policymakers, and practitioners who are all working in chronic disease prevention across Australia. And our goal is to really cultivate a dynamic and enduring future prevention workforce that has the capability to drive the co-design of applied and policy relevant research and then translate and mobilize that knowledge for policy and practice impact. So for those purposes, we also host these webinars. And just a quick reminder for all of you that this session will be recorded, and the recording will be shared at a later time for those people who registered today. So today's webinar focuses on weight stigma and women of reproductive age. And
you'll speak on? Yeah, because there's no hour.
Sorry, can someone has their microphone on, so if everyone could make sure they're on mute, that would be great. Anyway, so as I was saying, today's webinar is on weight stigma and women of reproductive age, and we'll be bringing to you community, policy, and practice perspectives. So we'll be delving into the issue of weight stigma for women who are of a reproductive age and going through the maternity care system. And this will feature a voice of lived experience as well as a research perspective. So to further elaborate and talk about this issue, we have with us today our two guest speakers, Alia Griffiths, who shares a passion for creating change after experiencing weight stigma during her maternity care. And she knows firsthand the impacts that this can have on not only the woman who is experiencing this, but also on the families as well. And she considers herself fortunate enough to be able to pursue advocacy of this issue at a state and national level, and hopes to bring through her journey and sharing her story the true impact of weight stigma to the limelight, so that it can be spoken about more openly and we can ensure creating safer environments for women and their children as well. And then we are also joined by Dr. Bryony Hill, who is the Deputy Head of the Health and Social Care Unit of the School of Public Health and Preventive Medicine at Monash University. And she is also a member of the Center of Research Excellence in Health in Preconception and Pregnancy. She's also an Australian Research Council DECRA Fellow and a Senior Research Fellow. And her research specifically focuses on the psychosocial and ecological factors that impact the health and well-being of women across preconception, pregnancy, and then their postpartum years. Bryony has a strong focus on weight stigma in her research, and as a result of that, she has been awarded a cumulative 7 years of Australian Research Council funding as the Chief Investigating Authority to understand and address weight stigma for women as well. So today we were supposed to be joined by Alia in person, but she did go into labor this morning and has delivered a beautiful little baby girl. So Bryony will be playing a recording that she sent to us this morning. And through that recording, Alia will share her lived experience with you, and then Bryony will follow that up with her research experience and expertise on the topics. So Bryony, if you are ready and you want to share the recording, it's over to you.
Hi everyone. I am so grateful to be here and sharing space and story with you all. My name is Alia. I have a 6 and a 3-year-old at home with me, and a third on the way. Hence the pre-recording, just in case. I am always so grateful to be invited into spaces like these. And usually when I share, I try and share really collectively, and try to capture the story and the voice of many. However, I was reflecting with Bryony recently, and given I am currently pregnant, this has really allowed me so many experiences that really speak to current weight stigma in maternity care, and really highlights the impact of policy in these spaces. So if you'll indulge me, this will be a slightly more personal and very current reflection on policy's influence, we could say, in Australian maternal care systems. I had vastly different experiences between my first and second pregnancies, and more so labours, which really started me on this path. I began as simply sharing and listening to story, which then progressed to consumer roles at both state and national levels, and most recently internationally, which I will always be so incredibly grateful for. While I acknowledge I am not an academic, I'm not medically trained, I am fortunate to be in spaces with so many brilliant people who are. So I constantly have the privilege of learning and growing in these areas. From these learnings and listenings, I had an incredible insight to what this current pregnancy could expect. Being risked out of models of care, additional and potentially unnecessary testings, microstigmas, throwaway comments, care clouded in policy. And unfortunately, this started quite early on. Just before I found out I was pregnant, we had just moved states. I was settling my 2 children into new environments, schools, socially, everything. I had just started an amazing and incredible new job. And then I found out I was pregnant, which I think we can all agree that just any of these factors individually are quite impactful, let alone all of them at once. So I obviously, began my due diligence. I looked into Aboriginal midwifery services around me. As I'm sure you can imagine, my social supports in a new state were quite minimal. So those care pathways were really incredibly important for me. I have been fortunate enough to receive this support in both my previous pregnancies. So really was aware of how impactful this was going to be and supportive for me at the time. I was immediately told by a GP that Aboriginal midwifery services just didn't exist. And I was automatically excluded from specific care pathways. So before I'd even met with anyone at the hospital, I was placed on a red path, so red high risk pathway. Despite a history of healthy, natural pregnancies and labour, no change to birth parents or circumstance, there was no attempt to even capture my previous birthing stories or experiences, just a very barbaric policy-based cut-off for care. I was automatically booked in for, early GTTs, OB appointments, additional ultrasounds. Until this pregnancy, I never even met with an OB, outside of a very quick 2 stitches post-birth with my first, which was a daze in itself, let's be honest. So, automatically being placed with OBs. My first appointment was at a very large hospital. Unfortunately, it was the first appointment of the day, did, the routine checks. And I remember her just looking at me and going, "Why are you here?" And quite selfishly for me, I had this profound moment of validation, like, yes, thank you. Why am I here? And then I saw her write on my file something like, suitable or approved for MGP. And I remember that feeling of relief, just seeing that, but also this feeling of how frustrating policy must be, not just for me as a patient, but for healthcare providers as well, working in understaffed, under-resourced spaces, increasing demands on time and workloads, and these arbitrary policies dictating who gets care, and knowing that this could just be one of many barriers stopping someone who actually needs it from receiving the most appropriate care methods. And I think we need to acknowledge that not only policy, but the framing of policy can have such a detrimental impact on women. Excuse me. I really strongly went into this most recent pregnancy aware of risk. I was aware of policies, of guidelines, and if nothing else, and nothing more, to simply be prepared as possible to navigate the stigma, not only medically, but also mentally too, that I knew I would come up against. I remember being told in my second pregnancy, I was allowed to gain, the high BMI threshold of 5 to 9 kilos. And this was by a very, beautiful and supportive midwife that I had an amazing relationship with. And I found myself beginning to develop some really, quite honestly, unhealthy behaviours around this. I began quite religiously, weighing myself, fixating on food, and quite ashamedly, I remember kind of feelings of like relief or happiness that would come anytime I would come up like pregnancy-related unwellness, so throwing up. Because in my mind, because of what I'd repeatedly been told and framed from policy, that hopefully that even if I was being sick, if I wasn't losing weight, hopefully it was stopping me from gaining weight. And just reflecting on that absolutely horrifies me. If I had heard that from any other person, I would be so absolutely heartbroken that anything or system or person could create that mentality in another living human being. And I unfortunately know, not just from my story, but from the story of so many others, that these policies dictate and influence these detrimental mindsets so frequently, unfortunately. So going into this most recent pregnancy, I really went, I can't put myself back into this position. I can't role model that disordered behaviours to my children. Also knowing I was pregnant with a girl this time, it really made me even more self-aware to begin with, that I didn't want to create in her a lifetime of stigma and unhappiness from utero. And so this time around, I had a 36-week checkup with an amazing OB, and she was like, look, it's routine that we weigh you. And I was really prepared. I was like, okay, I knew I could do blind weightings. I, had all these options available. And here I was this time around being so, carefree and unrestricted around eating patterns. I was intuitively eating, and I was like, back to the devil, so I looked down on the scales and it was 5 kilos I'd gained the entire pregnancy. And I was astounded. This one experience of restriction and fear to another mindset of, look, we're just going to survive the next 5 months, and seeing such an impactful difference. And not only the mental impacts of that, but clearly the physicality behind it as well, what that translates to. I had always said to anyone that would listen that the second a risk, an actual risk, comes to fruition, that was external to me simply existing, so outside of my Aboriginality or my body, then that would be my focus. But while my risk was simply myself, I really struggled with where to place that. And I do have to say, though, probably one time weight stigma really worked in my favour was my additional ultrasounds. So, and I selfishly don't mind admitting, I enjoyed seeing my beautiful girl's face when most don't get that opportunity later on. But also during one of these later scans, they were able to detect a hole in her heart. And it was amazing that in that one moment when I heard those words, I just had this profound thinking of, well, nothing else matters. Every, ounce of advocacy or liaison, my preferred birthing methods, or everything else just completely went from my mind. I still remember what I was wearing and looking down and thinking, those thoughts that stick to you, but so random. And I just went, all right, well, these are the clothes I must be sleeping in for the next, 3 days. They're not comfortable, but I'll just wear them. I had these instant thoughts, wheel me upstairs, emergency cesarean, let's just get her here safely and we'll start, no idea what I was dealing with. And obviously none of it happened. We were referred on. At the time, we received really minimal information from the sonographer. So I was so thankful that that first OB had granted me permission to attend a MGP. I had an amazing team really supporting me and just giving me space to kind of process what that could potentially mean for me and my baby. Being so heavily pregnant, 2 children at home, working full time, I knew I couldn't let my stress or fear take over that space. So for me, it was so important that I had that team walk me through that journey, especially when we had a 3-week wait for specialist appointments. That in one hand, rationally, I go, okay, that was, too concerned. They would have prioritised us, but still 3 weeks is a very long time. And what really stood out to me was this perception of risk from weight stigma, from the weight stigma lens, had been so ingrained and so strong. And then I found myself in what any parent would feel as an actual risk. And if anything, once I presented, my care became kinder. Any concerns in regards to her heart didn't impact my labour preferences or choices, my care pathways. We have a specialised treatment plan in place for the first 12 months of her life. We've met with cardiologists, specialist sonographers. It had gone from this automatic assumption of, oh, well, extra scans because your baby's so big, which she never was. It was that stigma from the start. And then moving into this specialist sonographer who just went, oh, these are never accurate. And I think, or more I feel, this continued messaging to women that our greatest risk to our children can be our existence, and to be so heavily supported in policy is just beyond damaging and detrimental. Like I mentioned at the start, I'm really fortunate to work with and be surrounded by so many brilliant people. And while we always acknowledge that in these spaces, no medical professional goes to work to intentionally cause harm, and I truly believe that, I really do, I also think we need to take that next step in our thinking to the fact that no woman enters pregnancy hoping for an adverse outcome. No one enters these spaces going, God, can't wait to go through months of, pain, sacrifice, change, in the hope something really bad happens. We enter birthing spaces naively, hoping for family, for love, for connection. And I hope that is a sentiment that we can always remember.
Okay, thank you. I'm going to stop sharing this screen and share my slides now while we take a moment to reflect on Alia's presentation. So thank you to Alia for pre-recording that, because obviously she's went into labour this morning, and she did give me permission to share a photo of her and her beautiful baby girl, only about an hour or two ago. So thank you, Alia. Now Alia so kindly shared that beautiful story and her reflections, and she's worked extensively as a consumer advocate and representing consumers on forums such as the Living Evidence for Pregnancy and Postnatal Care Guidelines. So she, as she mentioned at the start, she tries to bring the collective voice, but it was really lovely to hear her personal and very poignant and current story. And I'm going to follow that up now with the researcher perspective, which is arguably much more boring than Alia's beautiful story, but I'll try my best to be interesting. And so I'm going to bring to you 3 perspectives today, and that is weight stigma from community perspectives, policy perspectives, and then practice. And I'll demonstrate how they're all so interrelated. And I just want to acknowledge that I live and work on the lands of the Wurundjeri people and pay my respects to their elders past and present. So what is weight stigma? So I think Alia really beautifully captured what weight stigma is in practice. And we define it as the phenomenon of discriminating, stereotyping, excluding or devaluing a person where their weight does not comply with prevailing social norms. And in Western society and increasingly elsewhere, that is that social norm of having a thin body ideal. There are 3.3 million Australian women who are vulnerable to weight stigma every year, and women report experiencing 3 stigmatizing events per day. Yeah, per day, 3 stigmatizing events per day. And weight stigma is really prevalent across all aspects of society and particularly in healthcare. But why do we look at weight stigma specifically in the reproductive years? And there are a number of reasons. First of all, we know that the reproductive years can be a period of weight gain for women. And so the more weight you gain, the more weight stigma you experience. As I mentioned, it's extremely prevalent in healthcare settings. And of course, during pregnancy, maternity care, postpartum, and even preconception care, women are regularly engaged with, hopefully, the healthcare system. Women experience weight stigma in everyday life, including where they go to school, their employment, their healthcare, the shops, and so on. And so we can't escape it. We have to acknowledge and address it. Weight stigma elicits a stress response in the body and has adverse responses across physiological, psychological, and behavioural systems, and the effects are profound and can be debilitating. So it's really important that we do something about it. And if we're thinking about women who become pregnant, there are definite public health and intergenerational ramifications of weight stigma in these years. But let's take a step back. Beyond all these issues, weight stigma is actually a human rights issue, and that's because everybody deserves to be treated equitably, respectfully, regardless of their personal characteristics. And sometimes we forget that as researchers because we get caught up in our research topic, but we have to take a step back and remember that these are people that we're dealing with. So weight stigma occurs everywhere. It's ubiquitous. We get it from people around us in the broader community. It's everywhere in the media. Women experience weight stigma from their family members. We get it from our friends, other mothers, our own mothers, in the community, such as at the gym, the shopping centre, walking down the street. It happens at work. And as I mentioned, it happens in healthcare. And I'm going to focus a little bit on healthcare today because A lot of research has focused on weight stigma in healthcare, but it's also really really pertinent when you think about policy. So I mentioned weight stigma has profound negative impacts. So what are they? So weight stigma leads to lower quality of reproductive healthcare. It can impact uptake and engagement with healthcare. It leads to poorer mental health, depression and anxiety symptoms, body image concerns, stress, as well as poorer motivation and confidence to engage in healthy nutrition and physical activity behaviours, as well as unhelpful coping strategies to deal with issues that come up. And so the cycle between psychosocial well-being and health behaviours actually compounds each other. Weight stigma can lead to poorer pregnancy and birth outcomes. And we don't know whether that's because of this stigmatization itself or some kind of intermediate factors. Most likely weight bias internalization, which is internalizing this stigmatizing and discriminatory attitudes from our environment into ourselves and believing them about ourselves. That plays quite a big part. Weight stigma has adverse impacts on breastfeeding, uptake and continuation of breastfeeding, as well as we believe negative impacts in the longer term on both mothers and their children. And Alia did mention that intergenerational transmission of stigma. She didn't want her unborn child to have those same experiences that she did. So where does stigma come from? I told you it's everywhere, but where does it come from? How does it eventuate? And so stigma forms through societal and social norms that develop the culture around body size in our communities. And so it comes from all directions and it feeds on itself. Because if the people around us have a certain thought or attitude or belief around larger-bodied people, we tend to assimilate. We tend to try and move towards the norm, and so we are perpetuating this societal stigmatizing belief. Weight stigma also is highly prevalent in education and training, and it's particularly relevant in the context of healthcare, education and training, professional development, and so on. And that's because the people who are delivering the education, the training, the university courses, they live in the community. We don't live separately. Everyone lives together. And so, whether you like it or not, the social and societal norms and the cultural norms around body size filter down and infiltrate the way education is delivered. As well as weight stigma is highly prevalent and really perpetuated through policies and guidelines. And I'm going to talk about that in a little bit more detail later. But if you think about policies and guidelines, they direct the way we live our lives, the way healthcare is delivered, and the way we, engage with the community, the way we behave. And so if policies and guidelines are stigmatizing, they are going to then inform the way social and societal norms are formed and the culture that we live in terms of body size. That's going to influence the people who write the policies and the guidelines and so on. And so it's this perpetuating cycle that's reinforcing itself. So we have to try and break this cycle. So one of my PhD students, Haymanot Haylu, has been doing some fantastic work looking at the community perspectives around weight stigma towards women across the reproductive phases. And this is the first research of its kind. We know quite a bit about women's perspectives, their experiences of weight stigma, but less around how it is perpetuated from the community. But if you look across the three phases, there are lots of similarities. So one of the big things that comes out, and you can probably think of examples of this from your own lives, is that these negative, disparaging comments towards larger-bodied people, making negative evaluations of them based purely on their looks, assuming that they don't engage in healthy nutrition or physical activity behaviours without even asking, and treating people unfairly based on their body size or staring at them. In the preconception phase, there was one study that focused on physical activity settings, and examples that came up were things like there's not the right equipment for people to be able to go to the gym. So we're telling people, go to the gym, do exercise, but we're not actually supporting them to do that, as well as weight limits on exercise equipment. Now, of course, safety concerns are an issue, and often the stigma comes through not because there's a cut point on the piece of equipment, but it's the way the message is delivered, and it's this message of you're not welcome here. There is a lot of discourse throughout pregnancy that women should remain thin, grow about basketball on the front of you, but don't put on weight anywhere else. That's not allowed. As well as things like lack of availability of appropriate maternity clothes. And in postpartum, it's really similar, absences of suitable support, for example, for breastfeeding, and that general, you must lose weight, you must get back to your pre-pregnancy weight, and that kind of message of fat phobia in society. So Haymanat's also been doing some really interesting work identifying the drivers of weight stigma. So she conducted a cross-sectional study with over 500 community members across 5 different countries, both Western countries, including Australia, and non-Western countries, and identified characteristics of people who were more likely to hold stigmatizing attitudes and beliefs. So I don't think it's surprising that in Western countries, people living in Western countries held more biased beliefs. But there were still high levels of bias or biased attitudes present in the non-Western countries. So we definitely can't say there's no bias occurring in non-Western countries. People that hold the belief that weight is 100% under individual control were more likely to hold stigmatizing attitudes. And so this is called a causal attribution or controllability belief. So it's where we think that a person is 100% in control of their weight or their body size without acknowledging the complex nature of the development of body size, obesity, that body size is largely determined by genetics, a little bit by the environment and less by individual behaviors. We tend to flip it and think that the person is mostly in charge, in control. People who hold a high awareness of the thin body ideals in society are more likely to drive weight stigma, as well as younger people. So we have these characteristics, but also did this really interesting work where we were able to group or cluster characteristics of people together for those in 3 different ways. So we have this group here on the left, people who have a higher BMI that hold less biased beliefs. So that's probably what we might think of naturally, that people with high BMI are less likely to be stigmatizing. But we have these other 2 groups. So we have people with a low BMI who hold moderately high biased beliefs. And then we have this 3rd group of people with a higher BMI who have more biased beliefs. And so this one's much more interesting, because we're seeing that despite having a high BMI, they're still being stigmatizing. They're still having those stigmatizing attitudes and thoughts. And this may be because people are internalizing weight stigma, or it may be that they're trying to assimilate to the norm. Society tells me that I have to be a lower BMI, so I'm going to act like people who have a lower BMI. And so this is some really early research, but it's really interesting and can tell us where we might be able to target to address weight stigma in community members. Okay, so now we're going to switch to policy. So Alia talked quite a lot about how the policies of her maternity care determined the type of care she received. And the way this occurs is often through this blaming narrative that is perpetuated in the way policies are written that promotes weight stigma. So the blame narrative is that it's your fault that you're this body size because you're meant to be in control of your body. So in this way, policies can either be inadvertently or blatantly discriminatory. So inadvertently might be they're trying not to be, they're trying to be inclusive, but there's just some issues with the way things are worded, or they might be blatantly discriminatory. They might be completely focused on that individual responsibility narrative. And as I mentioned earlier, because policies guide the way we live and work, they perpetuate stigma in society. So we did this really interesting work, a report card of Australian policies that were related to obesity and women of reproductive age. And we looked at 41 policies, and we looked at factors that were associated with weight stigma. So did they mention weight stigma? Did they look at the causal attribution of obesity, so that individual controllability belief? And did they look at factors that are involved in the stigmatization process? So of the 41 policies, they were all national or state level. 3/4 didn't think or mention or talk about weight stigma at all. Okay, so already we have a lot of work to do. 30% of the policies had a purely individual responsibility lens. So even though we know that the environment is a huge driver of body size, and we have, policies that are looking at commercial determinants of health, environmental factors, that, almost a third of policies still completely were focused on that individual responsibility lens, and 0 strategies, none, addressed weight stigma in their mobilisation strategy. So that means they didn't, so strategies should be mobilised so that they can be enacted in, and then that means the policies can have their effect. No strategies looked at weight stigma in their mobilisation strategy. And so how did this kind of manifest in strategies? So even when both individual and environmental responsibility were acknowledged in policies, so that's about 60% of policies, they often were implicitly condoning of stigma. And this occurred through language. Often policies oversimplified the energy balance narrative, so that energy in, energy out kind of dominated, and that reinforces the stereotypes that we know of, that people with larger bodies are lazy, and that we know that's not true. Policies also had conflicting messages. So, for example, they might have a message that it's a human right for someone to choose their own behaviours. And so if you take that perspective, you are completely diminishing the environmental factors that contribute to body size. And so, there has to be a balance. And finally, it was very common for policies to just have poor wording choice. So, for example, if a policy was focused on nutrition and physical activity and everything was about that, if the person couldn't meet the nutrition and physical activity guidelines, the policy is saying that person is a failure. But what if it's not the person's fault, it's the policy's fault for not getting it right in the first place? So anyway, there's lots of ways that we can think about how policies are written that contribute to weight stigma. And I think we're only scratching the surface of it. And the more you kind of think about it, the more you read into and realize things can be very stigmatizing. And Alia mentioned like micro stigmas. And so I think some of these are micro stigmas. They don't even seem stigmatizing on the surface, but when you drill down into it, you're like, well, you are sending a message that, it's your fault if you have a larger body and that you don't belong here, and so on. All right, so now practice. So we've talked about community members, we've talked about policy and how that contributes to weight stigma, but what does it look like in practice? And again, there are lots of similarities here between how weight stigma manifests in healthcare to how community members drive it. And that's, of course, because community members also work in healthcare. So there are things like stereotyping, this insensitive and negative language use, accusations of dishonesty, and treating somebody differently because of their body size, models of care and so on. The interactions between healthcare providers and patients, for example, is unnecessary or frequent testing or screening where there's no other medical reason for that except for the higher BMI. Remember, BMI is just a marker obesity. It's not obesity itself. And BMI stems from white men. So when you use it at an individual level and not at the population level for which it was designed for, and then you use it in populations that are not white men, its utility is, completely diminished. And so we need to think more broadly about the way BMI really informs the way care is delivered. And there's another one that always sticks out to me, and this was one of the first things I read when I started researching the area of weight stigma, and that's refusal of fertility treatment and denial of services to larger bodied people. And there was this quote in a qualitative study I read that basically centered on a woman was refused removal of long-acting reversible contraception purely based on her body size because the doctor decided that she was too large to have a baby. And that really stuck with me, and I think that's what's really driven me to continue this research area. And Alia talked about policy a lot, and this can environmental factors in healthcare can sit really closely with that. And that's things like not having suitable equipment available on hand when you need it, not having to go searching for it and rummage and sharing when, the majority of the population are larger bodied. It should be on hand. Having unaccommodating environments that aren't welcoming, clinicians that have not had the opportunity to learn detailed knowledge around the development, the causes and the complexity of obesity, and discriminatory hospital policies, which Alia mentioned a lot. And so I was really fortunate to get some seed funding from the Prevention Centre to co-develop resources for antenatal care to address weight stigma. So we conducted workshops with women who had lived experience of weight stigma and midwives, and they told us what they wanted in terms of addressing antenatal care in practice. And so what did they want? They wanted representation of larger bodied women in antenatal healthcare services. So that could be through resources displayed in waiting rooms, in pamphlets. So 50% of larger bodied women will have uncomplicated, healthy pregnancies, but that wasn't coming through as the norm. There was a lot of conversation around risk. Alia mentioned risk. And this is that concept of absolute versus relative risk. So as researchers, we often report our findings in papers as relative risks, for example, as odds ratios, which might say, you're 4 times as likely to have this adverse consequence. But we don't go that next step and present the absolute risk, which might be 2%. And so healthcare professionals are working on relative risk, not realizing that they're actually catastrophizing sometimes in terms of how they're talking about risk to their patients and the women they're working with. And finally, they asked for education around weight stigma for clinicians, as well as opportunities to develop empathy for larger bodied people. And so they asked for things like short, sharp, interactive, easily digestible learning opportunities, as well as resources that could be easily implemented into clinic, such as signposts to remind you to have like I can't see the rest of my slide because the little person is in front of me, sensitive conversations, or that, the signpost above the scale reminding you that you don't need to weigh everybody, or just the person might not want to know what their weight is, and so on. And it's also worth noting that the participants in our workshops also wanted to affect policy change. There was a lot of conversation around that, but when you only have a tiny bit of money to develop resources, that was out of the scope of this particular project. Okay, so what's on the weight stigma agenda? Lots and lots of things. So research, we need to know more about where and how we can address weight stigma. We're starting to scratch the surface here. We need more evidence to break down that paradigm of weight-centric research and support weight inclusive care. Alia gave a really good example about how thinking weight inclusively improved her outcomes for her pregnancy. And so we need to remember that, but it doesn't come through in the literature, so we need evidence. And also, I just would like to everybody to consider their biases in general. We don't go out to be stigmatizing on purpose. It's coming from culture, community, but we do need to remember that it does influence the way that research is funded and published. And so we need to kind of stop and reflect before we look at a paper as an editor in a journal, or before we do our peer review, or when we're reviewing grants, and so on. At the community level, we can all have a think about how our community may be inadvertently contributing to weight stigma. At the policy level, if you're writing policies, if you're reading policies, if you're implementing policies, have a think about how they might be stigmatizing in terms of wording, discourse, and ensuring that we acknowledge the complex nature of obesity, and that the contributors to obesity are many and not purely under individual control. And at the practice level, education for healthcare professionals. So they're learning about weight stigma, they're learning about obesity and its complexities, looking at how we can change culture in practice so that it becomes second nature to not be stigmatizing, as well as making it easy. It's hard to change our habits, and so easy to implement strategies are the way to go. Okay, so there's so much happening there, so much to do, but I would like everybody to take home one thing from today, and that is that you can do something about weight stigma now. I often get asked the question of how do I write or talk about people living with obesity, and the number one response, and this came from extensive conversations with Alia and other people with lived experience, is that you really want to ask them, what are their preferences? That's the best way to talk about people with larger bodies. But if you're writing a paper or media or something, policy that you don't have the opportunity of directly engaging with a person on that one-to-one level, avoid the word obese. Try talking about a person as living with something that doesn't define them. Person first language. Avoid combative or catastrophizing language like war and obesity or crisis. And yeah, that's my advice if you're going to take one thing home from today. Okay, I feel like I've talked a lot. I just wanted to say thank you. If you're interested, we have a policy and practice pack for weight stigma available through Monash University. I'm always open for people to reach out to me, and I will hand over to Michelle now if there's any questions.
Thank you, Bryony. That was so insightful and such a beautiful presentation. Thank you to Alia as well for being so open and vulnerable by sharing her experiences today with us. And just, I feel very moved by the presentation because I'm sure a lot of us can relate to, what you spoke about today, but also begin to recognize our own internalized stigmas, and also the ones that we perpetuate subconsciously because of things like culture and living in community. So while we may be aware of it, we might not even know when we're perpetuating further stigma. So it's really good to see and be mindful from both a research, policy, and practice perspective. So thank you for sharing that with us.